Welcome back to everyone in the room and everyone online. I hope those of you who are online had as nice a lunch as we had here in the Mayor's Chambers. Thank you to the organisers for that. We've had a really interesting morning, focusing a lot on what's been happening here in the Czech Republic and reflecting on the European processes for HTA and medicines regulation. And we're going to move on this afternoon, and this block we're going to be talking about patients in institutionalized health policies, design and delivery, and we're going to be looking at best practice case studies from across the European Union and Scotland. Of course, we wish we were in the European Union, but that's another story. But before we get into that, we know that there might be a little bit of post-lunch slumbering, so we want to remember that you're involved in this fully. So could you take out your phones, and we're actually going to move to the next Menti question. So as we enter this session about health policies, design and delivery, we're going to ask, are patient organisations already involved in health service policy, design and delivery? And there are 4 potential answers there. So tell me what you think about this so I can gauge whether there's any reason we should be holding this conference or whether it's already happening that patients are involved. So I can see the answers coming in already. So we've got a moment, yes, partially. 3, no, not much. 1, yes, fully. So there's a very positive person. I'm going to let the score run up a bit. We're up to about 16 people at the moment. And just while you're gathering that, it will be interesting to reflect on how patients are involved. As we've seen earlier this morning, even within something like regulation, there are different ways in which patients or patient organisations are involved at different levels. And sometimes we need to think about that and create clear systems for that. So I think you're quite a positive audience. What I can see so far is from 31 votes that actually 20 of you are saying, yes, patient organisations are involved in health policy making partially. So that sounds like there's some room for improvement. 1 is really positive, saying it's yes fully. And there are 10 of you saying, no, not very much. Now, what I can't do in Menti, because I'm a statistician, I'd want to break that down to know which country is saying what. So I can't tell whether that's a mainly Czech response or a mainly European response. But I think that's quite a positive start to think that, yes, patient organisations are being involved in health policy making in some countries and in different ways. And we're going to learn about that more now. I think we'll take the Menti down. That's given us a good flavour. And we're going to move on to the next set of presentations. So here we have these best practice examples, and it's my pleasure to welcome Derek Mitchell to present to us about the Irish Platform for Patient Organisations, Science and Industry, EPSCO, and what they've been doing in Ireland. Derek, welcome.
Thanks, Karen, and thank you indeed to NAPO, to Robert, and the rest of the audience for inviting me here today. I'm just going to check this works. Aha, great. So, who are iPOSI, or what is iPOSI? And it's very interesting to hear the talk about the Czech model, and whereas iPOSI is potentially a model, we're quite a unique organisation in that respect, in that our origins were not your typical origin. And I'll give you just a flavour of the story of just how we've evolved over the last 15 years. But we were established by patient groups in Ireland over 15 years ago. And The point of IPOSI, and that stands for the Irish Platform for Patient Organisations, Science and Industry, is to provide spaces for patient organisations, but also individual patient advocates to have their voices heard, but more importantly, to have interactions with the other stakeholders, be they from the state agencies, from the regulators, from academic science, and indeed from healthcare industry. So you might ask how that works. So in Ireland, we have, just like in Czechia, we have about something in the region of about 150 or 200 patient groups. And over the 15 years of our existence, we have gone from about maybe 20, 25 patient groups to being probably the largest network of patient groups and individual patient advocates in the country. And I think that that point about focusing on the individual is something that IPOSI certainly emphasizes in our work. And I think it's really important in terms of making contributions to overall health policy. And I'll touch on that a little later. But IPOSI was set up as a public-private partnership. So we have originally a core grant from the Department of Health, who saw value in investing in the establishment of IPOSI. And that grant has gone through several iterations over the 15 years, and it now completely supports our patient education programme. And what that grant allowed us to do was it allowed us to leverage additional public funds through research funding organisations, European level, and then we charge the companies that join the platform a membership fee. So we're able to maintain our independence as an organisation. Everything we do from our governance level all the way down to our projects is led by the patient groups. And what that does is, certainly in our experience, is that it allows the consensus to bubble up, and that once patients are always leading, the other stakeholders are very happy to follow. So our three main activities revolve around education, advocacy, and information. And you've heard a lot of that kind of work already here today. And the types of activities that we do are listed here, and I can give examples of them in terms of the topics that we focus on. But every activity we do it with an impact in mind. And I think that's very important for patient organisations in terms of capturing their impact and making that very clear in terms of how they should be supported and by whom. So the three priority areas for IPOSI are access to innovation, and the last panel, I think you will agree that the challenges that exist in that whole area between assessment and reimbursement are challenges that exist in Ireland, and we try to tackle them as best we can in a neutral way, in a non-condition specific way. And we engage with the state agencies and indeed the industry around those challenges. And a couple of years ago, we released a patient charter around assessment and reimbursement. Our central pillar is patient and public involvement. And that's all about the role that we play is to facilitate inclusion of more patient and public voices in the health system, and in particular in health policy and health services, and indeed research and innovation. And our third priority area is the whole area of digital health and health information and what you might call patient data. So that's all about maximising the benefit of the use of all of our health information, whereas at the same time maintaining that balance by respecting the privacy and the consent that is so important when sharing information. So that is fast becoming a really big area that we're focused on. So how did we get to here, to 2022? Well, we were established on what was originally an EU think tank model that existed in Brussels and in many other European countries. And that was founded by in Ireland by a group of patient advocates who went to the Minister for Health and said, yes, we want charities and patient organisations to be research active and to be funding research, but we also need this neutral space, this platform that allows us to interact more systematically with the decision makers and stakeholders in health. So the Department of Health gave us an original grant, And what we were able to do was be able to match that with the subscriptions from the companies. So we have a 50-50 funding split. One of the key milestones in our own development was the origin. We were one of the original partners of EPATI, and the emphasis that we were already placing on patient education at that point has only blossomed and really magnified in the subsequent years. So our first Irish EPATI-like patient education program was launched in 2017, and we're now on our 4th iteration of that program. And what we were able to do over the intervening 15 years was through the individual advocates, some of whom were being trained and educated on our program, and indeed what you might call the health-interested public. So those are the people who are out there who are trying to navigate a system that is completely unnavigable in many cases in terms of healthcare, but they're interested in getting involved. And we made the decision as an organisation to include them in our network, and that has actually paid dividends in terms of our reach and our ability to reach public audiences. So we're now doing activities that are being designed to gain that public perspective in addition to our patient groups and individual advocates. So it's PPI, patient and public involvement. But I think in terms of maybe what NAPO and other patient groups are trying to figure out right now is, how do I become a respected partner? How do I stabilize what I've achieved today and make it sustainable? And I think from our experience, we had to focus on building the relationships in the first few years of our evolution. And we were known for creating those neutral spaces. And it was, I think, the value of those neutral spaces, the networking, the connections, that kind of outcome was being valued increasingly by people within the system. And so what we're known for now are what we might call higher level advocacy actions in terms of our own confidence that for any particular topic that we pick, that we have the power to harness a collective patient and public response to that topic and to channel that to the decision makers. So these are the kind of actions or the kind of outcomes that increasingly we're doing. So you might ask, well, what have we achieved? What was the point? And I think looking back now, it's easy for us to kind of maybe see the changes that have happened in the system, but it's very difficult for us as an organisation to say, well, that was because we were there. Because the truth is, everything we've done and everything we've achieved in partnership. So, and so much so that we're now looking at developing an impact framework for our organisation that's suited to the type of organisation that we have become. So it's no longer an impact measurement based on, say, a logic model or a return on investment. It's actually around what's called the theory of change. And it allows us as an organisation to measure our impact in terms of what we want to achieve, but how through our activities, we're actually helping other stakeholders to achieve the outcomes that they need to achieve. So, what's it like in Ireland in 2022 in terms of patient involvement? Well, if I'm being polite, and I am being polite today, I would probably say that the efforts to increase and improve patient and public involvement in Ireland are ongoing. There are an awful lot of people who increasingly recognise the value of patient and public involvement in the design and development of policy and services. But I think that the two key words for me are around that by involving patients and the public in the policy and services, you're actually improving both the efficiency and the quality of those. And it's those two aspects that I think a lot of patient organisations struggle to demonstrate how their involvement has improved both of those aspects. So in Ireland, the health system is increasingly including patient voices now more so than ever before. And a number of these opportunities that are listed here. But I think what's missing in Ireland is that overall vision, that overall, what does success look like? What's the end goal, if there is an end goal, or what's our short, medium and long-term goals? So we're advocating strongly for a roadmap for the health service to embrace at the national and regional levels, but also more importantly, a framework of involvement that recognises what we've heard today, the different types of organisations and individuals and the different involvement frameworks that are going to be necessary if we're going to move ultimately for a more person-centred healthcare. So to finish, and I know I'm slightly over time, but and I'm conscious of that we're in Prague, so Prague is another P in this, so hopefully Prague becomes one of the central Ps in patient and public involvement, but I'll just read this out because it's something that we feel very strongly about, and it's that public and patient involvement requires people with a passion and a purpose, with a place to meet and a payment for their involvement. It requires a willingness to pursue policy change with perseverance and persistence, while mindful of the need for practical application and in partnership with the health system. It's like iposy, it's a mouthful, but it actually captures what it says on the tin. So thank you very much.
Thanks so much to Derek for all those P's. I don't know whether they translate the same in the local language, but some important new P's there, Derek, starting by explaining the core funding that enabled you to create the platform for the partnership. And I think those are two really important areas that we might want to explore in the final discussion today. But there will be many more things from the case study, so I'm going to move on quickly to our next speaker, and it's my pleasure to invite Maria Petrova, who is legal expert and consultant from the National Patients Organization in Bulgaria. Welcome, Maria.
Ladies and gentlemen, colleagues, friends, it's a great pleasure and honor for me to be here with you today. I would like to use the opportunity to thank, first of all, of our kind hosts for this great event, for our big European family, and of course, of my colleagues from Bulgaria, which give a lot of efforts to make this, which I will present now, happened. I will show you 3 examples, best practices from Bulgaria, our experience, because I will be honest. Usually when I start presentation about patient rights, health rights, medical care, etc., I have to use expressions like, I'm so sorry to say, or I'm ashamed to say or share this with you. But today I'm very proud because I will share good practices of our National Patient Organization. As you can see, it was established in 2010, and this is not right over there. We now have over than 100 patient organizations. You can see in our website a lot of information about us because we have a history. But this organization gives us opportunity to involve patients in policy and decision making. These best practices that I will show you today, I figuratively desire to and create them like to be heard, to be seen, and to be understood as patients. So what I mean, I will give you some context because in Bulgaria we have the same problems, patients have the same problems as patients all over the world. And we just, first of all, want to be heard, wants to be seen, and wants to be understood. Everything starts in 1999. Bulgaria changed. After post-communist regime, we saw the creation of a National Health Insurance Fund, which replaced the Semashko model. And according to law, this National Health Insurance Fund must guarantee equal access to all insured Bulgarian citizens. What happened 10 years later? Of course, we found our national patient organization, and with some legislative challenges and changes, we had a small step to be heard. We start to be a national representative organization of patient rights, which gave us an opportunity to be part of legislative process of all of these changes. It was a small step, but it wasn't the last one. We go forward. And after this, in 2009, we got some changes in our Health Insurance Act, according which all, not only Ministry of Health, all other authorities must respect patient rights and give us a lot of opportunity to be not only patients, to be part of this process. After this, we got another small step. In 2010, you can see in supervisor committee of this health insurance fund, we got a legal representative of National Patient Organization, which was the first big step to be heard as a patient rights in Bulgaria. You can see what our laws say, and we have 9 members there, and one of them must be from this National Representative Patient Organization, which was the first step to be heard. But that wasn't enough for us. We want more. We want to be seen. Since 2015, we create something that we called Partnership for Health. Actually, I will tell you the real story. It was the middle of the summer when Dr. Hosarjiev called me. It was evening, and he said, we should do something big, and we should do it until tomorrow. What? I say. And he said, you must write some rules for this hybrid model in which patients can be involved in our government. How it would work? I don't know what to do. You can do it, he said. And all night we were chatting on Skype. I was writing the rules of this partnership. And the next morning we go to the Council of Ministers. They approve our documents, they signed it, and since 2015, by resolution of our Council of Ministers, we got this hybrid model. It is very useful because during this partnership we have a lot of workshops, sessions, seminars, discussion, and this was the next step of our patient rights to be seen, because government saw all the patients there, and according to the law, we have some rotation from these national patient organizations, but we always have our representative organization in this partnership, which is very important. Next step. As you can see, very important persons and authorization government states are in this partnership, but by the law, we always must have a representative of patient organization, which was the step to be seen. What we do after this? Okay, they heard us, probably they seen us, but we want patient rights to be understood. What we did? We create a patient portal, which is an integrative platform where patients can give a feedback about authorities. So you can see the numbers, how many patient stories we reach at, and how many lives we can change by this platform. This was the last step that we took to be understood. After they hear about us, they see us, but now by the patient stories, they try to understand us. But that wasn't the least step. Actually, I believe the patient rights and patient involvement in policies or decision-making is not only on a paper. We can change the law, but we can't change the hospital. This is still active, working children's infectious disease clinic in university hospital in the third largest city in Bulgaria. So our effort wasn't enough. But do we manage to solve all problems by involving patient organization in this policy or decision making? I think no. Shall we stop? Absolutely not. So what we want after this, our forward steps, next steps, we don't want just to be heard. We want to be attentively listened to. We don't want just to be seen. We want to be noticed. We don't want just to be understood. We want solved problems. So, what we are going to do? We are going to fight. We are going to believe, because we believe that the people's health must be the highest law. Thank you very much for your time and attention. And I will be glad if you have any question to answer them. Thank you very much.
Huge thanks to Maria for that really inspiring presentation. It's a good job I said that Maria was a lawyer there, clearly spending all night writing a legislation. I'd kind of given the impression this morning that it takes years to create legislation. That goes to show if you've built the right partnerships, if you're ready to take the call when it comes and you're ready to act, you can make a real difference. But I think that's an absolutely amazing example among many examples, which we will come back to there. So on our grand European tour of best practice examples now, we're going to move online to Margarita Sandos and to Leticia, who are from the group of treatment activists in Portugal. And they're going to tell us about their recent endeavours to lobby for a national charter for public participation. And we can see them well on the screen now, and our colleagues are going to be organising the slides of them. So welcome to you both, and I'll hand over to you for your presentation. If you would like to unmute, can you hear us now?
Can you hear us?
That's right, perfect.
Well, we're not seeing the slide, sorry.
Are the slides?
Do we need to change our feed?
Can I check with the people in the IT that the slides are being presented? That's it. Can you see them now?
Well, we see the room.
Oh, okay.
The slides are in the distance.
We can see your first slide, the conquest of spaces for public participation in the field of health. But maybe the IT system needs to just swap a lead, I think. So I'll just keep talking for a minute or two until they get the IT. So I'm just going to pick up something a little more from Maria's presentation, and then we'll come back to this presentation from Portugal, because again I thought Maria gave a very clear overview of how you started with representation on an advisory board, and then the Partnership for the Health Council, which was the legislation you wrote, and then further steps, but still more to do. So again, that journey of involvement really coming through there. And we think it should be working now? Yes. So Margarita, can you see the slides now?
Now, yes. Thank you very much.
Perfect. I will hand over to you. Thank you.
Okay, so hello to everybody, to everyone who's there in Prague. We are very pleased to be here. It was an honor for us to be invited for this important conference. And unfortunately, we are not able to be in Prague, but we are with you here in Portugal. And congratulations again for the organization and the idea of discussing this important subject today. So we present a little bit ourselves. More Participation, Better Health initiative is constituted by 15 patient organizations, one consumer organization, one Portuguese consumer organization, and it was since the beginning supervised by 2 researchers from the Center of Social Studies of Coimbra University, researchers that studies health and participation. So please, next slide. And the other one, please. I forgot to say next, please. And the next one, please. Okay, thank you. So nothing about us without us. Everyone here already heard about this slogan, I'm pretty sure. The will for participation in health decision-making process, we may say that actually started about 80s. We all know the history of social movement related to specific health conditions. And this is a slogan on which we may say that some of this social activism was built. And basically, this means exactly that no policy, no health policy should be decided without the direct involvement of those who are affected by that specific policy. And this is particularly important in health field. So we must talk about the Alma Ata conference that I'm pretty sure also that everyone there already heard about it.
Next, please.
Next, please. Thank you. Next, please. Yes, thank you. So I was talking about the Alma Ata conference, and actually this marked a turning point in health policy. It was, as we all know, since that moment that we started talking about health decision-making process and health citizenship, putting the citizen, the individual, and its rights to participate in the center of health politics. Next, please. And here in Portugal, it is important to talk about what happened after the Portuguese Revolution in '74 and the fall of dictatorship. Actually, our constitution brings to the Portuguese politics news regarding democracy, of course, but also regarding participation. And specifically, this major law says in its famous Article 64, which is related to our National Health Service, that our National Health Service has a decentralized and a participative management. And this remains until today. So this constitution is from '76, and already there we had this idea and this policy saying that our NHS has a decentralized and participative management. And this inspired all the following legislation regarding health policy.
Next, please. Thank you. Good. Yes, thank you. So the Constitution was from 1976, and it took 10 years to have the first piece of legislation enshrining participation. And that was just a detail in how to organize hospital service. So it took another 4 years for the first health basic law to specifically address the issue of participation. And as you can see, it was not a base by itself. It was an idea within the base on how to organize health policy. However, on a positive note, it stated that health policy should be oriented, among other principles, towards the participation of both individuals and the organized community. Next, please. And
the previous ones.
There should be one before this one. So previous slide. I think you skipped, no? Weird. Do you have one on ethics committees for health? Maybe the next one? Thank you. So, again, fast forward 5 years since the first version of the Health Basic Law, and we finally have a regulation about individual participation in health processes, specifically on ethics committees related to health. Here, people are invited to participate as individuals, as members of the community. Previous slide, please. Oh. Okay, that's the one. Thank you. And 10 years after that law, as you can see, we finally have regulation about associations for the defense of users of healthcare services. And this law is important because it also regulates a specific type of organizations that much later on will be set as the organizations that guarantee the participation of patients and users in primary healthcare. Fast forward one more, please. Next slide. Thank you. And so the law about the participation in ethics committees was reviewed in 2018, and in 2019, the Basic Health Law was also reviewed. This time, participation is specifically one of the bases of health policy, and it now has its own base in the law. The law also clarifies what participation means, and it's about the definition, it's about participating in the definition, the monitoring, and the evaluation of health policies. Next slide.
Please. So actually, the year of 2019, right before the pandemic, was very rich in important legislation regarding the participation in health decision-making process. As besides the revision of the Health Basic Law, we were finally able to be published, being published the Charter for Public Participation in Health. It was finally published as a law after around 3 years of what we may call a public national discussion on this subject. This was a patient-led charter developed by our initiative, More Participation, Better Health, in collaboration, as I said before, with the academia and the public discussion with other health, and also in a public discussion with other healthcare stakeholders that have proven successful to put public participation in the political and in the healthcare agenda. And this is right, the Charter for Public Participation in Health, and not exactly the Charter of Duties and Rights in Health, as it was mentioned in the conference program, I believe. Probably a mistake by us in communication with you, but actually the name is Charter for Public Participation in Health. So this charter includes some principles, some scope, some guidelines, and some suggestions on means of participation, of public participation in Portugal. Next, please. So we also think that it's important to share with you and to explain a little bit the process before our president signed the bill into law. So the process began when our initiative and many other health entities, because actually the charter was first signed by 100 health and organizations and health entities, these many other health entities and social organizations related to the health field launched a national petition to the Portuguese Parliament asking for the implementation of this charter. Actually, all these organizations wanted to formalize the public participation in health mechanisms in Portugal. So after 4,000 signatures, this petition was finally delivered to the Portuguese Parliament, and after 1 year of parliamentary discussion within the political representatives, two political parties presented two legislative initiatives related to this petition specifically. One was a simple recommendation to the government regarding more participation in decision-making processes, and the other one was actually a proposal for a law aiming the approval of the Charter of Public Participation in Health, and also instructing the Portuguese government to regulate this implementation. And this was an initiative from a party that calls Left Bloc. And we are currently now still awaiting for the Portuguese health ministers to regulate the law so that the Charter for Public Participation in Health could be finally a reality in all health services in Portugal. Next, please.
So the evolution of patient participation has been slow, but it has sped up in recent years, and it has sped up specifically since around the turn of the century. So in 1999, there was a law creating a decree law, creating a National Council for Mental Health that states the need for the participation of both patients and family members whenever patients cannot represent themselves. Then there's the National Health Council, like in previous presentations. There are also specific spaces for participation, like the National Council specifically for drug problems, drug addiction, and harmful use of alcohol. GAT is a member, or has been a member, of many of these participation spaces, and is currently on the Advisory Council of the Health Regulatory Authority. Next slide, please. GAT is also on these three different spaces for participation in the National Regulatory Authority for Medicines and Medical Devices. So we are part of the Advisory Council. We also sit on the plenary of the Health Technology Assessment Committee. But there's also another way for organizations to participate without being as members of committees. So there's this program called Incluir, which translates to include, and patient organizations are called to fill in forms to inform the decision of evaluators of medicines and medical devices. Then there are also other spaces of participation that I referred previously in both hospital and primary care levels. And these are basically, those citizen offices are basically ombudsman offices, ombudsman meaning representative fighting for justice and quality of service. And it's also symbolic that they're not called the ombudsman office, but the citizen's office. Next slide, please. There are also ad hoc or spaces of participation for specific issues that will not last in time or that have a defined calendar to issue conclusions. Some examples are the Commission for the Revision of the Basic Health Law, or a technical group independent from services that was set up to inform the health minister about other views regarding access to care, or the monitoring group on the implementation of measures of what we call the National Recovery and Resilience Plan. So the EU money to respond to the COVID pandemic, and that is being partially used in healthcare as well, either to replace or acquire new tools for service. So there's a committee doing follow-up on this one. Next slide, please. Well, sorry?
No, the previous one.
Is there a previous one or a next one with a drawing, purple-ish? Maybe the next one. Next slide, please. Yes, this one. So things have been evolving positively towards increasing participation, but we have already identified some challenges. So how to engage people who are underserved or marginalized in participative processes when there are social or cultural or linguistic barriers. As a first step, GATT with another organization has co-created this guide for migrant participation. And I say co-created because translators were absolutely essential in adapting the text to common language of the linguistic target communities. So they also created the content of these guides. Previous slide, please.
So to finish finally our presentation, we think that it's good to share with you some lessons we think we may take from our experience in more participation, better health, and also regarding all the Charter for Public Participation in Health experience. It is actually possible to build a true participatory initiative since the beginning, and we do believe that more participation, better health is an example of it. In a country like Portugal, where we may say that until 2015, the year that we launched our initiative, there was actually some distrust among patient organizations. And we believe that the More Participation, Better Health initiative has somehow changed a little bit that reality. And on the other side, we want to share some reflections also with you on the conditions that we believe that must exist for a successful participatory process in health that actually were already mentioned by the previous presentation. First of all, the legitimacy of the representatives, of course, and their autonomy. Mainly their autonomy from the political and from the economical interests. Also, probably most important, the partnership. Actually, equal partners relationship requires literacy from both sides. From social organizations, we know that, but also from our traditional political decisions and from political side. Also, human and financial resources. There is no participatory processes only based on volunteering. Feedback, also important, is giving feedback and regular communication within the whole process. Also, it is important to pay attention to the visibility of the participation. People must see and must accompany what is being achieved through the participatory process. Also, the involvement must exist since the very first day of the whole process. We cannot call people and social organizations to participate only to validate decisions already made. And finally, the transparency and the public information regarding all the process since, again, the beginning.
Thank you very, very much, Letitia and Margarida. That's a really great presentation. We are going to have to wrap up now. I'm afraid that we do need to move on to the next presentations. We can come back to your final thoughts afterwards. So thank you very much for that. Let's give them a round of applause. I'm going to move on now. The final stop of our European tour was to be in Scotland. And we've had apologies from Richard Norris, who has the dreaded COVID. We spoke to him this morning and he's coughing too much to be able to present. So I'm going to try and quickly, in just a couple of minutes, give you highlights from his presentation. Richard comes from an association of mental health service users. They don't call themselves patient organisations, and he ran that organisation for 20 years before going into the National Health Service to support the Scottish Health Council. And he came in at a time when there was legislation in Scotland which was saying that the National Health Service has to ensure that those receiving services are involved in and consulted upon the planning and development of services and decisions for those that will be affected by those decisions. In addition, there is a legal duty that there is a strong public and political expectation that the NHS will involve and consult patients. And that was written sort of 20 years ago. But more recently, there's been reflection in the law courts on what is meant by public consultation, because there is a feeling by many that public consultation means we ask and we get lots of responses, and some of us wonder whether all the time we've taken creating a response actually makes a difference. And this has been addressed in the courts, and the gunning principles are now in place across all health policy. And I think it's sometimes helpful to think beyond just health policy to wider policy. These affect all governmental policies. So first of all, a final decision has not yet been made when the consultation is issued or predetermined. The information provided about a consultation must relate to the consultation and be accessible and easily interpretable. So you have to get all the information you need to be able to engage in a consultation. There should be sufficient opportunity for consultees to participate. So in the UK, we have a general rule that it should be 3 months for a governmental consultation. And we know that in HTA systems, we often give 15 days. So there are challenges around that. Decision makers should be able to provide evidence that they took consultation responses into account. And these gunning principles have really been taken on board by a number of organisations recently, and you may want to reflect on them in your own countries. But going back to the general health situation in Scotland, the Scottish Health Council was established in 2005 as a national body, but with 14 regional offices in our 14 health boards, which are responsible for providing primary and secondary care. And their role was to support, ensure, and monitor patient focus and public involvement in all activities in NHS Scotland and in those 14 boards delivering healthcare. So their role was not to speak on behalf of patients or the public, but to ensure that patients and the public were being listened to. And they did this through a range of approaches by providing local support. They actually have a national citizens panel. They did research to look at whether they should implement citizens' juries, which is done in a lot of places, for example, like Canada. But they identified that actually they would prefer to have broader representation. So they have 1,000 people covering a cross-section of the population, from young people, older people, different regions. They provide a range of toolkits, and in particular, one of the most important is the participation toolkit and the evaluation toolkit. And this isn't for patients and the public. This is for health services to actually consider whether they are involving patients and the public appropriately. And there are certain standards that are set, and health boards have to show where they are, what level they're on in terms of participation with the patient and the public. And our Minister of Health visits each of the 14 health boards for an annual review, and they talk about their finances, they talk about their waiting lists and all the other things. But the Minister of Health also meets with the lead of the patient group within that health board region and says, are you happy with the way in which you have been involved in health service delivery and design? And I think that's a really interesting way of working, to say, have you made a difference this year? And so the background here is that the organisation was really trying to sort of support health boards, but would also highlight if a health board wasn't doing it well enough. And I'm just going to skip through the examples and try to go back. Maybe I can't go back, so I'll just leave that. Just to summarise, to say that my own involvement was this: when I was actually on a governing board of my local health board, and we took this very seriously because we knew that after we'd gone through the finances, the minister would be talking to those patients. And I can give you one of my best examples. Is we had a great patient panel, and they sat on our health board. We were designing a new hospital, 800-bed hospital, and it was really important to have the patient representatives walking with us around the hospital. They'd been involved in the design, but they actually helped us with the design of the gardens, with silly things like windows, just thinking in ways that the medics or the managers never did. And we could actually go around and say, that's the patient window, the garden is here because of what the patients told us. And that's what we want to start hearing. We want to start hearing, this is the impact that patients have made. But I'm now going to invite Derek and Maria to come up and take a seat at the front here and a microphone, and I'm going to invite Margarita and Letitia back online so we can, that's it. So we'll now have our panel discussion. So do we have any questions from the audience to start us off? Or maybe Robert, is there anything online coming through?
Yes, we had one question online regarding some examples of, is there anything that you tried to achieve but did not succeed? And if there is something of sort of, you know, not best practice example, but example which failed, can you sort of give us a bit of reflection of what went wrong and why you did not succeed in what we were doing? Thank you.
Sorry. The simple answer is yes, of course. And in presentations, you often focus on the positive aspects or the achievements rather than what you haven't achieved. But I think primarily where we find that the challenges exist is around culture. And if we are advocating for change and reform of a system where a culture is predominantly medical dominated, clinically led, without an embedded patient involvement enshrined in legislation, then the culture will always trump, for lack of a better word, what you are trying to achieve. But when we get in and when we involve ourselves in maybe the reasons why the culture, well, we know why the culture exists. It's how we can actually hope to change that in some small way. It's very interesting when we talk to the decision makers and even the innovators and the service providers, and they will tell us that, yes, it's the culture that's the problem. The culture is the reason why patient and public involvement is not embedded. And then when we ask them further about what their own work problem or their own work issues, and they suddenly realize that they are part of the problem because they're not doing it in their own little area. So I would probably flip that on its head in terms of there's lots of things that we haven't achieved, but one of the main things is about convincing people to look at their own small area, because if those small areas can make the changes within there, it's amazing the impact that actually will happen over time. So that's my answer.
And I can see Letitia and Margarita nodding there. So I'll come first to Maria, and then we'll go to Portugal.
Thank you very much, Karen. Actually, I found your question kind of tricky because nobody's telling his bad experience, but I prefer not call it a bad experience, just experience which made lessons for us. Because in Bulgaria, National Patient Organization have enough history, enough experience. Of course, we had some projects that didn't bring us what we want, but this was a small steps to achieve another, more bigger goals. So everything that we want to do, even if it's a bad experience, we can look at it as an opportunity, as a challenge, and probably some practices are working in some countries in Europe, but blindly reciprocating a practice is not the best way to solve the problems in all the countries. So now we share our experience, we give some history about this, but this is lessons which all of patient organizations have to take and learn by themselves.
Thank you very much. Any reflections from Portugal?
Yes, thank you to Derek and Maria for having already said it all. Participation may not work depending on the level at which you want to see change and the level to which you're engaging with. So a top-down approach from the government to solve a specific problem in a very specific hospital service will probably fail. So participation must occur at all levels of the system and with both official and non-official official focal points. And a very specific example of this would be in a hospital service, a specific service. We identified a problem. The usual script was letting some people out of the system. And a doctor, not the service director, engaged with us. It was not our, in this specific example, it was not our initiative, engaged with us to brainstorm on a possible solution for these people. And we came up with something. It had very little impact in the service organization. So the service director had no problem with it at all. And this did not require participation from the hospital consultative body downwards to the service. So a problem was perceived, a solution was designed and implemented, and it works. And it would not have worked if we had gone the official approach through the proper channels. So participation must occur and inform all levels of the system.
Just to add a small idea, can I?
Yes, please do, Margarita.
So just to say that for me, for us, one of the problems and one of the things that we still couldn't achieve is, as already been said, the culture. In fact, the way that the traditional decision makers and the political powers see the public participation, specifically in health, as a good idea is not the way that we can actually see the public participation in health processes. They must look at public participation, first of all, as a right, and also as the better way to achieve better politics. And I still believe, and I see that nowadays in the Portuguese government and and the nowadays politics in our country, that the political power look at public participation as an idea, as a good idea, and not as the better way to achieve better politics.
Thank you for that. And I think that many countries could reflect on that. We have a question at the back, so I'll ask our microphone volunteers to go back there. Just while you're doing that, I'll just reflect there that so important points about culture and context and using formal and informal routes. Those things are important when lobbying, in a recognition that, in a sense, sometimes consultation can be seen as a bit of a rubber stamp, and it's not really seen as making a difference. So we need to gather more examples of where we as patients and public have made a real difference and demonstrate that. Question from the back.
Yeah, I'm Martin Denner from the German umbrella organization of patients' organizations, and I've got a question concerning the options of participation, because if you've got so many options to participate, you've got to find persons who are able to participate. And I'd like to know if there are any structures of support or coachings or something like that, because patient representatives should know a bit the mechanisms of the healthcare system or the methods of HTA or all these things to have a good impact in the system.
Thank you, Marty, for that question about if we want to involve patients in all these things, how do we develop their capacity? Would anybody like to answer that one first? I can see Maria maybe lifting the microphone.
Okay. Of course, I can speak only for Bulgaria. It's very difficult to find that kind of persons who are patients, who have enough time, enough capacity to be involved in the policy on decision making. This is very tough because sometimes we have more than one problem to solve, and we have to be represented at the same time for difficult topics, and we don't have enough persons to do this, which is probably problem of other countries too, because patient organizations are not enough funding to make this capacity and have enough educated staff to be involved really in a process, not only as a listener, not only as participant, but as an actually active part of this process.
Derek.
Yes, thank you. Just to add to that, so in terms of training and opportunities to become trained and more educated, there are a number of groups that are active in this space, and some of them have been mentioned already. EUPATI, the Patients Academy, and I know now that there's a EUPATI national platform in Czechia.
Not yet, but we're hoping.
You're hoping, okay. Well, so we actually used to coordinate the national platforms in EUPATI, and they're pretty much based on the IPOSI model. But there are also the other European groups like Eurordis run summer schools for rare disease community, and there are a number of other groups at the European level that can provide you with content that then you can contextualize in your own national level. I think for training on advocacy and understanding parliamentary processes and regulatory decision making, that's a really it's an area that lacks, I think, specific training for patient groups, and very often patient groups are dependent on other patient groups with maybe more resources to try and educate them in terms of that. So it's something that we're trying to do in IPOSI. That's probably more what you might define as skills-based training. So EUPATI focuses primarily on knowledge. So, but it's only the combination of both, with the knowledge and what I would just call just enough education to perform. So you don't need to be a trained clinician, you don't need to be this horrible term of professional patient. You just need just enough to motivate you to then give you the confidence that your involvement will be impactful.
And just to comment on that EPATI does cover regulation as well, but one of the other things that are important alongside the tools is mentoring for the people that are already on the committees, like the Committee for Orphan Medicinal Products, actually shadowing and supporting new members coming on. That's something we find is very important in our own HTA committee, alongside having a paid patient and public involvement officer like the ministries group here, having paid individuals whose role it is to support and find individuals with expertise, because you in this room are not just patients, you all have skills and experience. So we've heard Maria's a lawyer. I know that Robert's an economist. You know, we aren't just patients. We need to make the most of those skills we have in our communities. And I'm going to give the final word to Portugal. Is there anything you would like to add to this discussion about how do we build capacity for patients to be involved in these kind of committees?
Well, we're obviously all on the same page, and so mais participação, melhor saúde, the initiative, aware of these needs, and set up a training program for patient organizations. You didn't need to be a member of the initiative or a regular participant. You could just register for the workshops, and we had them with people from all over, from the public healthcare service, people with experience of governance, law people, and we also had a variety of subjects on which workshops were organized for capacitating patient organizations. So from ethics, representativity and legitimacy, to social networks and activism, to there was a visit to a medicines factory for people to understand how medication is produced and packaged, and all the safety and labeling issues related to that. We had workshops on financing, public financing programs of different care levels, so that people could be aware that something that works for a hospital is different for a primary care unit. We talked about tools for organizing work and for registering information. We talked about data protection. We talked about access to information, about the law, about access, the right of access to administrative documents, public registries. So those needs that were pointed out in the question and on previous answers were also our needs, and something that has already been hinted, but I think not yet fully said, is we don't need just to pay people who actually do the representation job on the committee or on the organization, because we also need people to provide support services to this. So we need clerks, we need computer people, we need a lot of functions to be fulfilled so that patient participation can be effective, and it can only be effective if it's truly organized before the real participation contact happens.
That's really helpful point. So they're explaining a range of workshops that you're providing based on the needs you've heard, but highlighting that the resources are also about the equipment you need, the offices you need, all of that infrastructure alongside human resources and knowledge. And I think Derek's going to have the final word of this session.
Yeah, so just it struck me in terms of the answers coming through about the sustainability of this, because you obviously need to keep doing it, because people only really have a certain amount of time to dedicate to involvement, and training processes need to be annual, and they need to be reaching out as far as possible so that they can actually pull in the people that will end up becoming the next future patient advocates. And one final point about education, and I'm kind of merging it with the previous question in terms of failures, that healthcare professional education is something that we in Ireland, we have failed to get patients as educators into the curricula and into the courses. And we've been engaging with the likes of the regulators of the sector and the providers. And again, we come up against that culture barrier that very often it's seen through a just do no harm first. It's safety first, and involvement tends to be on a level that is just incomprehensible to maybe the traditional medical healthcare professional, and that applies to a lot of healthcare professionals. So again, it's a challenge, but I do think that there's impact to be made in that area.
And I think that there's an interesting example from EULAR, which is the European League Against Rheumatoid Arthritis, and they've really worked over years about how they involve patients in their scientific conferences, special patient groups, co-development of patient-relevant outcomes. We can see some of those examples, and we need to look at those clinical examples, not just the patient organisation examples. That's been a really great discussion. We could go on. We'll continue it over coffee. We're running a little bit late. Can we say that we return at 2:35? Is that okay? I can see nodding in the room. But please thank all of our speakers here in the room and online. Thank you so much to Margarita and Letitia in Portugal, and to Derek and Maria here in the room. Thank you.